Our first speaker today is Dr. Deepak Kapoor. Dr. Kapoor is the chairman and CEO of Integrated Medical Professionals and president of Advanced Urology Centers of New York. His medical background is diverse with both laboratory and clinical experience, both in academic and private sectors. Dr. Kapoor's expertise includes basic science research in molecular biology, as well as extensive experience in oncological and reconstructive surgery. Under Dr. Kapoor's leadership, the Integrated Medical Professionals have become the largest comprehensive urology group practice in the U.S. He has published and lectures extensively on both clinical and medical issues and serves on a number of medical advisory boards. Dr. Kapoor.
Thank you. Good afternoon, everybody, and thank you for the kind introduction, and thank you for taking a few minutes to have me speak to you about this important subject. As mentioned, I am representing both an academic as well as a private sector group. I'm on the academic faculty at Mount Sinai in New York, as well as we run Integrated Medical Professional, which is the largest urology practice in the United States. Our group does about 1.5% of all the urology volume. We have about 100 physicians in 55 offices throughout the New York metropolitan area. So to give you a little bit of a background, as an overview, PSA-based prostate cancer screening has greatly altered the way that we diagnose and that we treat prostate cancer. The USPSTF, through a flawed and non-transparent process, issued a one-size-fits-all grade D recommendation that recommended, believe it or not, that no one should get a PSA done. No asymptomatic man should get a PSA done. What you're going to see from the data that I'm going to show you, and I think Dr. Ginsburg will support, is that we're seeing fewer diagnoses of cancer and an increase in the incidence of higher grade, less treatable disease. The USPSTF Transparency and Accountability Act will reform the process to ensure that the American public continues to get access to vital life-saving screening services. So let's start by looking at what happened with PSA-based screening. But PSA is something known as a serine protease. It's something that's produced in prostate tissue, and it's exclusive. It's not cancer specific, but it is prostate specific. It does exist in very low level in other organs, but for the purpose of our discussion, it's prostate specific. And we can see, excuse me, prior to 1986, when PSA was introduced, the death rate from prostate cancer was relatively flat. From that point in time, we can see that the death rate from prostate cancer declined from 39.3 per 100,000 down to, in 2012, 19.6 per 100,000. Excuse me. Which is a decline of about 50% over that period of time. Furthermore, what we're also seeing is that prior to PSA-based screening, the death rate from prostate cancer, in other words, the number of people that were dying specifically of prostate cancer, went down from 53% of men diagnosed. Now the 10-year survival is up to 99%, which is absolutely extraordinary. So what we're seeing is that with prostate cancer, the key to therapy is early detection. Early detection saves lives. Now, the argument that you're going to hear is that prostate cancer is an indolent disease, that it's not fatal, that people die with prostate cancer, not of prostate cancer. And I can tell you, as being in the trenches on this, that nothing is further from the truth. Prostate cancer today is the second leading cause of cancer death after lung cancer. Almost as many men will die of prostate cancer as women will die of breast cancer, and no one is saying that that is an indolent disease that doesn't require therapy. In point of fact, one man will die every 24 minutes. So during the course of this hour, 3 men in the United States will die specifically of prostate cancer. The real tragedy is virtually every one of them could have been prevented if the disease, as you can see, was caught early enough. Now, the problem with the USPSTF process is it doesn't consult with experts. No one with experience in the treatment of cancer is there. It develops recommendations in secrecy because it's exempt from FACA and the Administrative Procedure Act. It's the only government agency that's able to set payment policy that is exempt from these from this. And as I said, exempted from FACA and the APA, not required to hold meetings in public, not required to consider public comments, and not required to disclose its methodology. Since the USPSTF issued its grade D recommendation, one size fits all, which basically said that nobody should get screening, and it allows the secretary to deny coverage for screening, we've had a very significant effect. What we've seen is, as anticipated, a decrease in the screening rate from prostate cancer. But unfortunately, the men that are being, the decrease in screening is not the older man that would not benefit from it, but younger men that would benefit from screening. This slide, again, this will be provided to you, but this line right here shows a decrease in the incidence of prostate cancer, and most troublingly, and this is data from our group, which is the largest study that's been published on this, is that we can see a shift. The USPSTF wanted to decrease the diagnoses of low-grade cancers that didn't need treated. In fact, that incidence has stayed the same. What we're seeing is an increase in the number of people with very aggressive disease. Now, back when I was a resident, which was a long, long time ago, we used to see nearly a quarter of men present with disease that was metastatic and already spread. That has really gone down dramatically. But in the last few years, since the USPSTF recommendation, we're seeing increasing number of men present with disease that has already spread outside the prostate, and once the disease is outside the prostate, it is inevitably fatal. So we are seeing a shift to non-treatable disease. So we were worried about a public health disaster. We just didn't expect it to happen so soon. So there's also an economic impact. For those of you, you all have fiscal responsibility for the United States. If you diagnose a prostate cancer early and it's treatable, it's the cost of $9,000 to $30,000 per quality adjusted light year. Advanced prostate cancer costs $80,000 to $100,000 per quality adjusted light year. So not only is there the human tragedy of men that could have been saved dying, there's also an enormous economic burden for not taking care, doing this. Now, the big thing is that the recommendation was untimely. The use of surveillance was already increasing. 3 out of 4 men over age 75, and we were developing tools, molecular and diagnostic tools, to help us identify those patients that needed treated versus those patients that didn't need to be treated. So this couldn't have come at the worst time. The technology was being developed, and then the USPS pretty much stopped men from being diagnosed, which is really a tragedy. So just to sum up, the USPSTF Transparency Accountability Act requires a balanced representation of specialty providers. It requires public comment, and it requires consultation with relevant stakeholders. So this is a relatively minor tweak to what the USPSTF does. What it basically does, it says that right now, the only government agency that has the ability to make policy that affects payment is going to be subject to the same degree of oversight that every other agency that can affect payment. So in summary, PSA prostate cancer based screening dramatically improves survivability. There's been adverse trends since the grade D recommendation, and these trends will result in a major public health disaster, both in terms of the human and economic impact. The USPSTF Transparency Accountability Act is absolutely necessary to protect access to vital life-saving testing for men who may have prostate cancer. Thank you.